All right. Thank you, everybody, for joining for our 1 o'clock meeting. Anything said or shown on the screen is liable to be recorded and posted publicly, so just be careful with that. And I think, take it away, Amber.
Super duper. All right. Good afternoon. For those of you I don't know, I'm Amber Rice. I'm a medical director down here in the Tucson region, and I chair the education committee. There's a couple other folks on here that might not know each other, so maybe we can just go around and just say hi and briefly introduce ourselves.
I'll start. I'm in the room by myself. I'm Shelley Bissell. I support these public meetings for the Bureau of EMS.
Jenny, do you want to go ahead and introduce yourself?
Yes, can you hear me? I was working on getting my mic to connect. Okay, awesome. I'm Jenny Wyatt. I'm the EMS program director for Mesa Community College. I just took over for Sean Newton, so I've been in the position for 17 days now. So,
Oh, wow.
Welcome. We'll go across our screen here. Heather Miller, I know you're on the line as well.
Thank you, Dr. Bradley. This is Heather Miller. I work for Kingman Regional Medical Center. I'm the pre-hospital coordinator, trauma program manager for our institution.
All right. Brian.
I'm Brian Smith. I'm the pre-hospital program coordinator at Flagstaff Medical Center.
Thank you. Jordana.
Hi, can you hear me?
Mm-hmm. Yes.
Perfect. Sorry. My name is Jordana, and I am part of PACES, one of the parents with the voting member.
Great.
Excellent. Thank you for joining. And let's see, Cynthia.
I'm Cynthia Wadier. I'm the pre-hospital coordinator at Banner Del Webb.
Welcome. Thank you. Marissa.
I think I'm the only Marissa. I'm Marissa Salgado. I work for the Bureau of EMS, Base Hospital Program Manager.
Thank you. Noreen.
Noreen Ablin, Bureau of EMS. I'm the Trauma System Section Chief and Pre-Hospital Coordination.
Thank you for joining us. And I'm Gail Bradley, Medical Director for the Bureau of EMS and Trauma System. So I will hand it back to Amber.
Super duper. Okay, so today the goal of the work group is to pull together some training that we could distribute that would be appropriate for a sort of statewide audience, taking into consideration the new recommended changes for the trauma triage guideline, which have been largely reviewed by most of our subcommittee groups and agreed upon. And so now we'd like to put out some education so that the different regions can use that to begin to educate their folks and inform their trauma practices locally. So I will put up, I'm going to share.
And while Amber's bringing that up, what we are trying to do with the PACES group, so a big thank you for Jordana for participating as well. She's also, I don't know, are you still certified, Jordana? But she has EMS perspective and has been a PACES committee member for a couple years. But we've really trying to start pulling in a PACES member to each of our educational subcommittees to make sure that we have a pediatric focus addressed. So this curriculum does definitely have some pediatric specific criteria that need to be discussed. But I just wanted to call out that that is one of the things we are going to make sure we do moving forward is to include someone from PACES. So thank you, Jordana, for participating.
Thank you for letting me.
That's awesome. So can you guys all see the PowerPoint?
Yes.
No, perfect. Okay. Okay, so I tried to begin formatting it. I largely took what was available from the ACS website, their sort of initial training. And then Gail and I thought that we should expand it quite a bit so that we could elaborate on some things and maybe give some examples. So I think what I'll do is I'll just kind of walk through slide by slide. I'll give you sort of a brief overview of what's in here, and then we can go back and kind of hit slide by slide and see if we have anything that we want to recommend changing. So essentially, there's a couple of introductory slides about the update and the update process, a brief overview of how the 2011 guideline was laid out, and then how this guideline is new. So basically being that it's not so algorithmic and reflects how assessments occur. And then I took some of these slides and broke them up and added some additional ones. This is an additional one I added just to talk about the guideline, talk about the different tiers of the guideline and how it's sort of meant to be read and interpreted. And so I have that for each of the sections. And then this basically goes through each section. And I tried to be clear which things that were new or clarified or reworded. And so it basically goes through each box as to what's been added. I added a slide about calculating the motor score, and then just kind of go through and discuss shock index, since that might be a new concept for some folks. The yellow box, we'll talk a little bit about these in detail as we go through them, but just so that you have an idea of how it's laid out, and then what was added to these boxes that was different from the previous guideline. Talk a little bit about anticoagulant use. This is in the EMS judgment section, which was added. And so we'll talk a little bit more about that in detail. And then some examples here, which we'll go through. And then really that was sort of the meat of the guidelines. But then in Arizona, we do some sort of specific trauma care things that we wanted to remind people of. So things that might be specific, which aren't necessarily touched on in the guideline, are things like airway management, SMR, TXA, EPIC guideline, pain management for trauma. Those things could be other general care principles, which we don't want people to forget about that they exist, and particularly things like TBI management, which is a big deal in Arizona. So I put in some slides largely pulled from Dan Spate's presentations. This comes from our TTTG, sort of how we lay it out of who gets SMR. They might be a little too wordy, but and that's basically kind of it for the presentation. So there's about 40 slides total. We definitely have some room to add a few things. If there are things that seemed really, really extra, we could remove them. So I think I'll just kind of start from the beginning then, and we'll kind of just go slide by slide through and see how far we get.
So, and Amber, I wanted to bring up, thank you for kind of doing the big overview and adding some additional slides. One of the things Amber and I met ahead of time to talk about, well, what are the parts that we need to add and really focus on with ACS? So I think they did a really good job going through some of it, but there's definitely some portions that need more explanation, kind of the new focus on GCS and shock, kind of a modified shock index. And then the EMS judgment, because I think that's the part that is going to be, it's not black and white. And so we need to give some examples of how to teach this. The one thing that I found when I first presented this at STAB is I kind of assumed that audience would have read the literature to back up kind of this evidence-based guideline. And there was a lot of hesitation to adopt this as is. And so I then brought back to a follow-up STAB meeting kind of all of the data. So the question is, you know, as we push this out statewide, do we want to include any of that data, knowing that that is pretty high level? I mean, it's written at a trauma surgeon level, but do we feel that any supporting data is necessary, or do we maybe list that as a reference at the end for additional supporting references? You can go to, here's the list of articles published that help support these changes. Because I think there was definitely some questions at the STAB meeting, the first one. So just wanted to bring that up just to kind of think about as we go through that. Is ACS did publish a number of articles to kind of support these adjustments to the guideline.
Mm-hmm. Yeah, definitely. I think there's definitely probably some room to put some of that in, particularly as it relates to some of the areas where there were a lot of questions. And then we could add additional stuff as resources at the end. But I think it's a good idea to think about adding that as well. So as we go,
I was going to say the other part that I did ask Amber was whether she or one of the other EMS faculty would be willing to consider kind of recording this in the Articulate format, similar to the patient refusal training. just because I think it is really nice with something of this magnitude if we can come up with consistent training that agencies can implement and really just put that training into their whatever training system they use. So she has said she will consider it. So that would be awesome if that's available to the state too.
Yeah, I think once we've sort of finalized the content, I think that would not be a huge ask. So for this one here, these were basically taken right from the ACS slides. This one particularly, really just sort of the purpose of having a trauma triage guideline, why it was updated. So really the main reason was that this guideline was from 2011. So it was from over a decade ago. And we wanted to make sure that they improved it. So their goals were really to make sure that we reduce time and variation in the decision-making process, and then had the opportunity to reduce under and over triage. So obviously we want to sort of hit the sweet spot with triage. We want to make sure that the numbers are, that we're over triaging to a certain extent, but not excessively. So those were the main goals for creating the update. Inclusion of EMS input. So this guideline update did include a survey that was distributed to a lot of the national organizations and trauma. They convened a expert panel and then did some systematic reviews of some other relevant published literature that was a little bit more current, using a specific process for sort of adding or removing criteria. And in the bottom here, you'll see there's a little bit of explanation, the sort of statistical process that they used, so that they had a sort of bar that the data had to hit, or that the change had to hit, so that it was meaningful. This slide just goes through the 2011. Yeah.
Sorry to go back to that one. So that is one of the sections that there is an article that was published on about. So that would be kind of one where when I did the second step presentation, sorry, I'm trying to make my screen smaller. There is the article, the National Trauma Triage Protocol, how EMS perspective can inform the guideline revision.
Mm-hmm.
So that would be kind of one slide to consider. And then specifying what the 5 systematic reviews were as well. So those would be 2 slides to consider maybe adding in there. So I will see if I can send those over to Shelley to share as well.
So say those 2 slides again. You had
one are the 5 systematic reviews, so kind of calling out what those 5 reviews were. And then the other was I did a screenshot of the actual journal article that was published talking about how EMS input affected these guideline updates.
Okay.
Let's see. I don't know if it'll work in the chat. Let's see if I can paste it in the chat. I don't know if it works. No. Okay. I will send it to Shelley and then she can share here in a minute.
Yeah, and I can definitely add in some bullet points from those 2 the reviews, and then the reference for this one.
Sounds good.
Okay. Then the 2011 guideline, this kind of walks through the 4-step process, the sort of algorithm that was laid out in the initial 2011 guidelines. So this is really just a review so that people refresh their memory. And then we dive into really what is new. And so basically moving from something that was a sort of 4-step sequence to more of a 2-tiered process to say, we're going to look at the highest risk folks and make the decision quickly on those, and then have some considerations for those that are more moderate or lower risk trauma patients. So versus being an algorithm, it's more how the assessments are generated on scene. And the idea for this one is to get to the transport decision sooner. And so I just added a little slide. This was one I added just to explain how the guideline is intended to be read. So it's intended to be read from sort of top to bottom and left to right. So you start at the top to identify those, sort of immediate trauma patients. And then they've laid it out to be sort of a gradient or likelihood of serious injury, so that as you move down, you get to sort of a lower likelihood of injury. And then another one I added just to explain the 2 tiers. So the first tier is the high risk for serious injuries. So this, based on the literature they reviewed, were criteria that they felt should put people in the highest risk category. So they basically used two different things, these two red boxes here, which will blow up for the further slides, but basically injury patterns, which they describe as like rapid visual markers. So things that you'd be able to identify quickly with a visual inspection, and your mental status and vital signs, which is more of the physiologic indicators that would suggest potential for severe injury. So that's the first tier. And then the second tier being these moderate risk for serious injuries. And so these patients, and this is where this will depend on the trauma system that you work in, but transport to the nearest trauma center, but not necessarily the highest level trauma center. So in the second tier, we look at those mechanism criteria, so the mechanism, and then in there on that last box that you'll look at is the EMS judgment. So sort of layered on top of all of the stuff you've already looked at, you moved all the way down. They're not in that severe injury group, and now you move down, and sort of the last thing that we consider are those things that might change your decision, right? So bump you up or bump you down, those things that we consider more judgment pieces versus strict criteria. So we'll get into that, and I think is where Gail was talking about, is where all of the nuance to this is in that section. So in our red criteria, again, we read this from left to right, and so we're looking for severe injury patterns, and so and then we look at the mental status and vital signs. So if they meet any of these criteria, they should be the ones that go to our highest level trauma centers. And so when we look at what is new in this box compared to the sort of algorithm box from 2011, they basically have clarified or reworded a couple things and then added one new thing at the bottom. So the things that they clarified or reworded were basically, they used to say elbow to knee. They used to be very specific about what they meant by proximal extremities. And so they took out that wording, so that really we're just saying penetrating injuries that are proximal extremities. So gives you a little bit more sort of flexibility in what you consider a more proximal injury. And then they added the word suspected to a bunch of these, just to say that you didn't necessarily have to have evidence or a picture of a skull fracture, but if you thought that someone had a skull fracture, that would put them in the injury pattern of a red. The rest remain the same down to the bottom, where they added the active bleeding requiring tourniquet or wound packing with continuous pressure. So it used to be more of a arterial injury sort of description, and now they're just saying anything that you have to put continuous pressure on to control the bleeding is something that would be significant bleeding. So those were the changes here. I didn't really do anything other than sort of marked what was new. So any questions or comments on this one? Changes, additions? And then I clarified some of it here, just to sort of list out the specific things that were clarified or changed. I don't know if we need this one or not, but it's just sort of additional description of what was changed.
I think any additional, for anyone who's not familiar with it, I think the more details we can give, the better.
Okay. This was a ACS slide. Nothing was really changed. Everyone looks very happy here. Sort of trauma patients. So in the mental status and vital sign box, again, this is sort of just demarcating. They have put green arrows where they have new things, and they've highlighted box for things that may have changed. And so really what has changed is this age-related vital sign criteria, so age-related blood pressure criteria. And then one of the significant changes is that they went from a total GCS calculation to a motor GCS score calculation, which is much less of a calculation really. And then added in some respiratory markers. So added in hypoxic patients or need for any sort of respiratory support would put you in this red category. And then again, the sort of shock index or modified shock index calculation here without really a lot of clarification necessarily on what the value should be. And then heart rate and again, for over 65, same thing. I can't see the chat, so do you guys have something? I heard a bling.
Shelley just
That
said
was
she
me.
got the slides I sent.
Oh, okay, perfect. It won't let me see both.
We can go over those at the end.
Okay, perfect.
Yep. Totally fine to go over at the end.
So I added in a best motor response or motor score explanation just to remind people of what the motor score is. So essentially, they say less than 6, which means that anyone that's not following commands. So one of the examples they give in the training is you could ask, like, can you look at me, or can you squeeze my hand? So we're talking fairly simple commands. We're not talking about complex commands. But if they can't look at you on command, or if they can't squeeze your hand and follow a simple command, then this would be, I mean, that's essentially your cutoff. So it makes the sort of mental status GCS calculation much easier to obtain.
And I think for this one, maybe under the talking points, or if it's going to be recorded, that could be included as well, as maybe adding in some more of those examples. Is, can you look at me? Can you squeeze my hands? I think from the pediatric perspective, most kids, once they're verbal, they'll be able to follow commands in this. Obviously, the pre-verbal child or anyone with, developmental delay would not be able to. But again, that would be erring on the side of caution of activating. And I think certainly those young infants are often hard to figure out if they're injured or not anyhow. Any thoughts on that, Jordana, from a PEDS perspective?
Do you think we need a go ahead,
Yeah, I
Jordana.
think the special needs and stuff is going to be the hard part of understanding if what their baseline normal is. Trying to identify that as with a head trauma is going to be even worse. Unfortunately, you kind of have to know what their baseline is, and that's you're going to have to ask an adult or somebody who else is with them.
Mm-hmm. Yeah, for sure. Do we need a separate slide for PEDS?
I would say probably yes, just so that that's a thought process for whoever's on scene first to say, if they aren't responsive, is this a baseline normal for them or not? I mean, hopefully the parents have, if it's a vehicle accident or something like that, the parents have it indicated on their vehicle or in their back seat with them, but that's not always the case.
Yeah, I just mean in terms of sort of calculating like a PEDS GCS. Like, do we want to put anything in there about what the equivalent response would be?
I don't if they're they respond to, they might have a communication device, maybe sign language that they respond to. Just because they're nonverbal doesn't mean they can't communicate at all. So I don't know how you would want to add that as a measuring tool. That would be kind of difficult, I would see.
Yeah, and I think in general for trauma, I think because of that, it's not going to happen. No one's going to an interpreter for a severely injured patient. I just mean like the equivalent motor score calculation for a smaller PEDS patient. Like what would you you know what I mean? So they for younger kids, if they're moving, withdrawing to touch, withdrawing to pain, it's similar, but
yeah,
they're obviously not going to be able to.
Yeah, you can definitely do a slide like that. I would think that'd be a good idea.
And maybe start with, something with like nonverbal pediatric patients. Because I think sometimes people assume like a 3-year-old can't follow commands, but a verbal 2-year-old or 3-year-old may be very able to, hey, squeeze my hands, squeeze your hands, and you've got your motor score of a 6. versus someone who, whether they are hearing impaired or other barriers that could block that. So, trying to think how to word it. And then I think also adding in, if family is on scene, inquire if patients at baseline, if nonverbal, because that may be something where the parents say, no, they're doing what they normally do when they reach out to me. This is normal behavior for them. That a parent or guardian could be able to share that an EMS provider may not know.
Something like that.
Hi, it's Brian.
Yeah, Brian.
So in this case, this is in the highest risk category. We're saying you may not be able to assess whether their GCS is less than 6 or not. So shouldn't they still be going to the highest level trauma center as the rest in that group would?
Not necessarily. I mean, I think what we're looking at is so you've gotten past the injury pattern part and you're looking at their mental status and vital signs. I mean, if the only thing you have to go off in a pre-verbal child is this, I mean, if everything else looks normal, you can't just assume because they're nonverbal that they need to go to a trauma center when they don't meet any other criteria in here.
Okay, I think that might, since this is all relating to that high risk category section, though, that might get confusing. I'm just saying, I mean, I don't know, maybe everybody would get it, but it seems like the place we're talking about right now is in the highest risk category that says go to the highest level trauma center. But now we're making an exception to that if they can't follow commands.
Well, we're not making an exception. We're just saying this is how you would evaluate a motor GCS score in a child potentially. That you couldn't take every nonverbal child to a level 1 trauma center. I mean, that doesn't, outside of anything else, that doesn't make them a high risk person. You're trying to rule them into the high risk category. And if they met no other criteria and they're nonverbal because they're a year old, but everything else would exclude them from the high risk or for serious injury group, you couldn't use the fact that they're nonverbal as your justification for transporting them to a level 1 trauma center. Because we've already said we're moving left to right. So if they don't meet any of the injury pattern criteria, and now we're looking at whether or not they have any physiologic criteria that they would meet.
May I comment?
Mm-hmm.
Okay, so I like the note that you had in there previously. Just the good reminder to everyone, like check with the parents, check for the baseline. I'm going to use my niece as an example. She has cerebral palsy. She's 7 years old, nonverbal, VP shunt, seizure disorder, etc. She's got a big history. So she is definitely someone that you wouldn't be able to assess the same way, right? So, and a lot of times she does go to the highest level of care, but she may not need that. So I do like that you're going to just throw in that reminder to check with parent what their baseline is, etc. So I think that's good.
Yeah, I think, the goal is to try to make sure, and that's why, thank you, Marissa, and also Jordana, that's having the perspective of When we've done these trainings, I don't think we've necessarily kind of thought about all of our pediatric patients, especially those that may have other, underlying medical conditions, and making sure that we do some carve outs so we're not automatically overactivating these, because many times these patients will be with family who can give you really important information to help you decide. If the family member says this is not their normal, then that should hopefully help EMS to say, okay, this might mean that their motor score is actually a 5 and not a 6, and I should err in taking them to the highest level trauma center.
I think that's perfect.
They didn't have anything in the ACS stuff, Gail, that I remember that excluded children.
No, I mean, they did a really good job with most of that. There were just a couple parts that I felt like if we're rolling this out statewide, we really needed to expand on some of the education, the GCS change being one of the bigger ones, and then the EMS judgment section at the bottom being the other big section too.
Yeah.
So I don't feel like we addressed this part a lot.
Yeah, and I think we definitely could run some of this language by some of the other like pediatric trauma center folks. Within PACES or outside, just to see if it makes sense to them, but it would be a good starting point. Oh, no. Okay.
We had a comment in the messages part that from
Mhm.
Jenny, can we change the word parent to caregiver to cover
Yes.
all the special situations? Thank you.
Mhm. And so this slide, again, just highlights the, I don't know why it says over so far. The sort of specific changes that were outlined. GCS less, or motor GCS less than 6, it used to be less than 13, but now we don't have to calculate. Can you look at me? If they can, they pass. And then systolic blood pressure calculation for children, which was added as well. Because the shock index calculation might be new for some folks, I put a slide in just to clarify that heart rate over systolic blood pressure and the meaning of it. So we would normally consider a shock index less than 0.7 to be fairly normal. And then what we're really trying to do is help create a sort of cutoff. And the general trauma cutoff that we use is 1. So in other words, your heart rate is equal or greater to your systolic blood pressure. And this specific finding is obviously predictive of increased mortality, and they've linked it back to need for massive transfusion protocols and admission to intensive care once they get to the hospital. So it is a marker of severity of injury and need for significant resources. So but let me know if you guys think that this is unclear or needs more or less explanation.
Hey, this is Cindy. I really like this. Just giving this information, especially to the, with the field, so they can start really looking at that. Because obviously when you start getting an even larger gap, that means the patient's in trouble. I just don't know if you want to talk about the types of shock or just keep it as basic shock.
Yeah, I think in trauma, I think we're generally thinking of hypovolemic shock. But it definitely is predictive of poor outcomes and morbidity and mortality in other types of shock, like distributive shock from sepsis and things like that. So I don't know if you guys feel like we need to clarify further, but.
No, I just think this will be really good for the team for education.
Yeah, I think it's helpful. I think it's more helpful than thinking of things in maps and stuff like that for trauma patients specifically. And it gives you sort of a very defined cutoff, which is helpful.
Yeah, and Amber and I were talking about this, and if all EMS kind of remembers from this is if my heart rate's higher than my systolic, this patient's probably sick. That's kind of like a simple way, ACS definitely did a simplified version of this. I think that will help them identify it. So I like putting the extra information in there for education as you have it up here, Amber.
Yeah,
There's
also
also-
go to the previous slide. I feel like I missed something on the previous.
This one?
Yes. Sorry, I'm just reading.
That's okay.
Okay, got it.
Okay. The only
Thank
thing
you.
with this one is this shock index cutoff number is fairly specific to adult patients. So there are different calculations to use for children. I don't know if we want to be more specific about that here. We could say adults or because obviously children might be much more likely to have an elevated shock index just based on their normal physiology.
I think putting this is just the adult would be important. I think for education, you could put the peds portion on there. I just don't know how much it would be used in those high chaotic
Yeah.
situations.
Yeah.
But I know for me, when I was writing, there were certain things, I had cheat sheets. And especially when it comes to peds, as soon as that call kicks out for a pediatric patient, you're immediately going to your quick pieces being like, okay, if you know that your peds was, ped versus vehicle, right away that this could be a major trauma and you're refreshing on the way to that call. So,
Yeah.
so I don't think it would be time wasted to put the peds portion on there. I don't know about anybody else.
The only thing that I'm thinking about, sorry, I'm printing the article that kind of supports this behind me. If you hear a printer chugging, killing
yeah.
trees. So under mental status and vital sign, if we go back up just one slide there, it does specifically call out for pediatrics. So the shock index is really being used for the adult population or 10 and above. So I feel like with kids
Oh,
0
I
to
see
9,
what you're saying.
ACS very specifically in that age group is basically saying if you have a blood pressure that is less than this.
So maybe I say age greater than 10 here.
Yeah, I would, just so that it matches, because I think the way that the
Yeah.
algorithm from ACS, they have 10 to 64 and then kind of your geriatric patient population. So as you separate those 3 categories out, I want to make sure we try to keep consistent for that.
Yeah, I see what you're saying there. That's actually helpful that they have that like written like that, because then we can just use their age cutoff. Because this is
Yeah.
10 to 64. So then we could just say 10 plus, because that would, then you should be in a sort of normalish range. Okay. Good thought, Gail. Anything else on the shock index one? We could put just a reference slide at the back that had a list of values. I don't know how helpful it is. It's much harder to use in pediatrics. Maybe we just leave it 10 plus and use just hypotension in children, because they use just a hypotensive cut.
I mean, it's hard with the hypotension with kids because as soon as they're hypotensive in a bad way, but it's kids. They don't like to give us warnings.
Yeah,
Till it's
exactly.
too late.
I concur. They did add it though for children. Before they did not have a lower age for children in there. So that is helpful. If we go to the yellow category, so similar to the red category, this one's meant to be read from left to right. And so it starts off with mechanism and then proceeds to EMS judgment after you've gone through the mechanism of injury. So essentially what we're doing is we're looking for a certain level of mechanism and then using our EMS judgment items to sort of move people up or down in the risk category based on, the presence of any of these risk factors. So the ones that were new are this partial or complete ejection and significant intrusions. They sort of clarified some of this. And then the new part, age under 9, unrestrained or unsecured. And then in here, they used to have some other verbiage. Did I break this out? I did break it in a different slide. A rider separated, pedestrian bicycle rider thrown or run over, and then fall from a height greater than 10 feet. And they do clarify in their explanation the difference really between extrication, so entrapment versus confinement. So I just put that as another sort of bullet point to the side. They, so this is sort of what's like a little bit additional explanation. So they really added the need for extrication. And they do clarify this a little bit more in the notes and some of the other documentation that they have supporting about what exactly they mean. I don't know if we need to go into more detail than this, but they basically say that they give some examples about cutting a post or popping up in a door doesn't mean that they were extricated. It just means that time greater than 5 minutes and or impingement of the patient. So I kind of put that as a bullet here, but I don't know if that's enough.
Yeah, I like that when they, I printed the article, that's what I was kind of do, just because they did finally publicize it, so it doesn't have accepted in big black letters across some of the data, but
yeah.
So it specifically says regarding extrication, a systematic review showed that extrication of any duration was a significant predictor of serious injury in adults and children, and that predictive utility was restrained down to greater than or equal to 5 minutes. So based on these studies, the panel added extrication criteria back to the guideline without a specific time requirement. So that was kind of why they added that piece in there. And I see Jenny's got her hand up as well.
Yeah,
Yeah.
I deal with curriculum for EMT and paramedic, and it does not separate this as extrication when dealing with medical patients or trauma patients. It just says extrication. So, and that's in our text, the AAOS textbook. It doesn't. So I'm just wondering where you got this information and if we need to see if there's a bigger change that needs to be made.
Yeah, so that textbook is actually it's going to be quite more out of date than the most recent articles that were published by the American College of Surgeons as part of this systematic review. So the data that Gail's reading is quite a bit more updated than what's going to be in that AAOS textbook. Yeah.
Yeah, so this is from, and like I said, I did the presentation in June, like late June, I think. And at that time, it wasn't officially published. So this has come out sometime between late June and now the final publication of this. So, but that's just the verbiage that they have with the specific data to back that up. But I think that is, for anyone who's been in the system for a while, we used to have extrication in there, but it was greater than 20 minutes and then it was taken out. So now we're adding back in. So I think having that explanation, so maybe just including, what time, and then let's see, the exact verbiage was, extrication of any duration was a significant predictor of serious injury in adults and children. So maybe just say extrication. Yeah.
Predictor of what?
Of serious injury in adults and children. And the predictive utility, if you want to get into that detail, was retained down to greater than or equal to 5 minutes.
Period of 5 minutes?
Greater than or equal to. Which I think that actually does a pretty good job, because if all they're doing is popping the door open, that's really not extrication. That's going to take, 30 seconds or a minute.
Do you want this up here more, Gail?
I think it depends. I mean, if we're going to have kind of a recorded version, that's one of the things that can maybe be verbally explained versus putting everything on the slide. What do you guys think?
I can definitely add the reference in here as well to that article.
Yeah, this is, I will send it to Shelley rather than reading it off to you. I'll send it to both of you guys right now.
Okay. And then the other modification was that they used to have ejected from automobile, and now they've basically say any separation. And then a fall higher than 10 feet.
So sorry for the the automobile, it's actually, so it says rider separated from transport vehicle with significant impact, i.e. motorcycle, ATV, horse, etc. So I think that that is a good kind of recognition that this is not just like ejection from a vehicle, but if someone's riding a horse and they're ejected from a horse or separated from the horse, that is included. So it includes motorcycle, ATV, horse, etc. is what they say. And they did say specifically that they broadened the type of transport vehicle for greater application to children, just kind of for the pediatric tie-in as well, just as a side note.
This part?
Mhm.
Yeah.
Pardon?
Yeah. I see that. Yeah, those are the changes. Okay, then we can put those references in there as well. And then,
Brian,
oh, hey, Brian.
could you go back to that again?
Yeah.
That rider separated where it says not
Uh-huh.
just ejection from an automobile, because up towards the top we have an ejection that refers to autos. It just seems that not just ejection from an automobile, because I think this rider separated topic deals with open compartment kinds of vehicles, whether they're ATVs, horses, motorcycles, or whatever. Would it be better to word that not ejection from automobile if we want to leave that in there rather than not just ejection from an automobile? Because they're kind of, it seems to me like they're kind of different topics.
Can that just be deleted?
What?
Probably. I could put rider separated or ejected. Because that was not new. So I think I see what you're saying, Brian, because it used to just say ejected. And now we're adding in that they separated. But because we're just adding in the new stuff and not referencing the old one, you could miss the fact that it's still also includes partial or complete ejection.
Maybe I'm wondering if we might want to just specify maybe some modifications, maybe say, because extrication, so maybe say additions / modifications in the top. And then maybe rider separated. Maybe we just take off the not just part and then kind of keep it the way they have separated. So that way we know, like, okay, we still have our ejections. These are the parts that are new.
I don't know. Does that clarify that, Brian?
Yeah, that's actually, I like that. It's just that mixing those two with ejection versus separated from an open type vehicle, it seems to me to be confusing. So not having it there is better.
Okay. Yeah, I see what you're saying though. Okay. Okay. And then the last box in here, and we may need to add some more in here after thinking about it. You guys let me know what you think. But in the EMS judgment box, this is sort of meant to be additional considerations, not solo considerations, right? So nothing from this category necessarily places you in a high-risk trauma group, but could impact your decision whether or not to transport somebody who's maybe more moderate risk based on the presence of one of these. And so this is the part that is a little bit more maybe nuanced and more difficult to explain. But what they added here was low-level falls in young children and older adults with significant head impact. anticoagulant use, and they've clarified that this is all traumas with anticoagulant use, not necessarily just head trauma. And then suspicion of child abuse or any kind of special healthcare needs or high resource healthcare needs individual. Staying in this category were burns, pregnancy greater than 20 weeks. And then the bullet point that children should be triaged preferentially to pediatric capable centers when possible. So I don't know if you guys have any specific questions on that. Gail and I thought maybe the best way to illustrate this concept would be to give some specific examples. So go ahead.
And the other part too, and I sent the article to you and Shelley on page, it ends up being, let's see. We might want to include for this one, I think on page 8, it has some specific, like the data about that. And it's like a little paragraph that we could almost copy and paste from ACS. It might be more information, but I think it does it. It's a nice brief summary, like the rationale of why they clarified low-level falls and PEDS. So kind of maybe including those 2 paragraphs for low-level falls and anticoagulation use. And then getting into examples.
These 2?
Yep.
Okay.
What are you?
So if we
So kind of including that, here's the modified criteria. Number 1 could be like the title of it. And then the body be like, here's the rationale. Because I think the key thing, especially with like ground level falls, there was a lot of discussion at STAB and there's different opinions on this, but I think that this does a nice job of explaining, like, this is a really common occurrence in the elderly population. And so we need to look at kind of the totality of the patient, as opposed to just saying any ground level fall needs to go to a level 1.
Formatting's going to be weird.
My facility, we actually just updated some of our trauma guidelines per ACS, but kind of got specific into ground level falls. I could forward that to you if you want, just because our population is so elderly and we were having some of those issues that everything was activated.
Yeah, I think the ACS.
About your internal? Oh, sorry, yeah, go ahead.
Yes, it kind of goes, with what's going to be a trauma yellow, trauma red. Don't know if that's helpful for you at all.
I think that would probably get us into a little bit of trouble because there's a lot of disagreement amongst the trauma centers about how they want to activate. Even as an example, within the Banner system, each facility has different activation criteria. So I think I would probably try to lean away from using any hospital specific one and really sticking to, this is for EMS to decide where they're going to take the patient. So kind of maybe putting in these, like, here's the background of why they made these recommendations. And then I think once Amber gets to that next section, we can go through some of the examples that she and I kind of just created that would hopefully help EMS, help them understand, like, what do we actually mean when ACS says this now?
And I mean, I guess what is significant head impact to some may not be the same for others.
Yeah, and that's where I think some of the examples, like, we're not going to be able to it does really get into EMS judgment's going to be dependent on their experience. How many times have they seen patients and what their patient population looks like. And so we came up with some examples and certainly open to more suggestions to help hopefully paint some of that picture. Because both with the minor falls and anticoagulation use, it kind of gets into that piece of it there. Amber, I'm amazed that you are doing these edits real time.
Yeah, I'll just put all the references to these 2 specific, there's a bunch of references. I could put them all in the box, in the notes, if people want to reference any of those papers. And then, so here were some of our examples that we had. Um, 80-year-old male playing golf, history of AFib, and is on Coumadin. Oh, I don't actually say what happens to him here. So essentially, this was one of our examples of a ground level fall, low level fall, blood thinners, but someone with a sort of isolated, no signs of significant injuries, totally awake and alert, normal vital signs, ambulatory. So in that EMS judgment piece, the sort of risk factor for anticoagulation is probably not going to push you to necessarily take this person to a level 1 trauma center, just because he doesn't have any other significant signs of injury. Sort of in contrast with the next example, which is a patient who would have fallen from her bed, still low level fall on Coumadin, but now this person has a large bleeding scalp laceration, seems a little bit confused, but still technically following commands, and has a deformity to her right humerus. So this is someone who doesn't necessarily meet the red criteria on her own, right? Outside of maybe the bleeding part, but really doesn't necessarily meet the red criteria. So it's still in that sort of moderate risk category, but because of the sort of signs of multiple injuries, that Coumadin might push you to be an additional factor to push you to transport this person to a level 1 trauma center. I'm obviously happy to change or add any of these cases. We kind of just made these up to make a point. So we could definitely add or subtract anything from these.
And I think maybe our dispositions, when we were talking about them, like this would not necessarily need to go to the highest level trauma center or a trauma center. So we were just, like Amber said, we just kind of threw out ideas that in our mind, if we were to see patients, which ones would we think would need to be activated versus not?
Right. Oh, this one I forgot to finish typing. So this one would be a 75-year-old on Xarelto. Who is in a MVC. So this patient has a seatbelt sign with bruising and abdominal pain. So do we need additional stuff in this one?
Maybe say MVC, no airbag deployment. Or I would say airbag deployment because that's most likely how he got the abdominal bruising. Airbag deployment, but normal vital signs.
So this is another one, again, who doesn't necessarily meet any red criteria, solidly be in the moderate risk group, but has some signs of a potentially significant internal injury. The Xarelto in this situation might be something that would make you consider transport to a level 1 trauma center. That was the idea with this one. And then we have one more example, which is a little bit younger individual who's similarly on blood thinners for PE history. Guess I could type it out. She was involved in an MVA with airbag deployment as well. She doesn't have any seatbelt sign, any abdominal pain or chest tenderness on exam. She's ambulatory with normal vital signs. She didn't hit her head or lose consciousness, and she also has normal vital signs. Or I wrote that twice. So this would be an example of one who was a maybe lower risk patient at baseline on a blood thinner, presumably no other significant medical problems, and doesn't have any objective signs of anything that would make the Eliquis be a significant concern to you necessarily. So this, again, a patient where that clinical judgment might say you don't necessarily need to take them to a trauma center. I think those are fairly clear. Yeah, Brian?
So I continue to be confused on how this is flowing. I'm sorry.
Mm-hmm.
When you go back up to that yellow box where this issue of anticoagulants is, because there's stuff about trauma centers, and then there's stuff about level 1 trauma centers. And if you look at this down at the bottom, it says, if concerned, take to a trauma center. It doesn't say the highest trauma center in the region.
Yeah.
So if you look at use, so I think we need to make.
So on the full
I
box,
think this
Brian,
is going through the highest level trauma center, like that. I think that goes back to my point on the pre-verbal, non-verbal child. I wasn't trying to say we shouldn't take those exceptions, like the caregiver can tell you, oh no, this is perfectly normal for this person. I was only talking about the one line where it said, if in doubt, and we're talking about a GCS less than 6, that they should go to the highest level trauma center, because right now it just says trauma center. Previously, in the 2011 guidelines, there were boxes that related to the highest level trauma center. There was a box related to a trauma center, and then there was a box that said you could take them to the local ED. So now we don't have that box about local EDs anymore. So we have all these other people who might not meet the other criteria that now we want to raise them up just to make sure they go to a trauma center. So I just want to make sure that I'm understanding this, because you've been relating this to this anticoagulant use to whether they should go to a level 1, but that's not what this box is about. Do you see what I'm saying?
Yeah, and I don't mean a level 1 trauma center per se, but like in this one, if you look at the full criteria, the ones who do not meet red criteria should be preferentially transported to a trauma center, so the yellow criteria, as available, need not be the highest level trauma center. So we're talking about here patients who would not meet the, I guess maybe I'm using I said red in there, but what I'm meaning is trauma center. So they don't meet any of the yellow criteria. Right? So we've ruled them out of the red criteria, and now we're in the yellow criteria because they had maybe a crash or something, but they're not necessarily meeting any of this yellow criteria. Right? So they were in a car crash, but there isn't significant intrusion. They weren't entrapped. So they're not necessarily meeting this yellow criteria. But if they were, on, like in our example here, if they're on this one, like here, right? So this is a low level fall. She's on Coumadin. She would not meet the criteria for transport to a trauma center at all. Except for now, she's maybe a little bit confused, but she's still got a GCS motor score of 6 and a deformity that still puts her in, maybe you could take her to an ED, but now you're saying because she's on the Coumadin and she's got this scalp laceration and like things aren't completely normal with her, we think we should take her to a trauma center versus not.
Right. That's right. And I think that's the way it reads. It's just you were referring to level 1 trauma centers. And
oh, well, I think I just mean the yellow box. So someone that wouldn't meet the criteria for trauma center evaluation by the yellow box. I think that I speak about it level 1 here because in Tucson, that's kind of all we have. we don't have like a bunch of different levels of trauma center here. So I think of
Right.
all the trauma centers as being the one, but yeah, you're correct. It's,
So my question is could we change the colors of these examples that we mean to be yellow to
Oh,
those
yeah.
examples are yellow?
sure.
And then if we have
Oops.
anything else that's in here that's going to work for the other level, then we can make those red.
Yeah, I'll make them kind of orangey because the yellow doesn't show up very good.
Yeah,
Yeah,
that's not
it was just the standard font.
fine. If it doesn't work, it doesn't work.
Yeah, I just hadn't changed it yet. Yeah, I certainly could try not to make it reference the red necessarily. How do you spell Eloquist? Here we go. Yeah, I see what you're saying, Brian. But yeah, you're correct. I think I'm just misspeaking. In our area, it's all level 1 trauma. But yeah, I could see in other areas it would not be. And that's all I had for examples. There were other sort of EMS judgment consideration ones. I don't know that any of these are as, I don't know, common or confusing maybe, but we could certainly add examples that of some of these other ones as well. I just think the ones that come up most often are these low-level falls in the elderly on anticoagulants.
Yeah, I think, you know, I wanted to make sure we definitely got into the anticoagulation use and low level falls because that is more nuanced. I'm just looking at kind of the suspicion of child abuse and special high resource healthcare needs to see what they added for that, just because we might need to provide. Let's see. So, in regards to special high resource healthcare needs, so this is referring to, I was actually interpreting this the wrong way. So this is talking about comorbidities. That injured patients with special healthcare needs related to comorbidities, including ventilator dependence or VAD devices, may require the resources and expertise. So I think that paragraph is probably helpful, kind of what we did before with the special healthcare needs. Adding that as well to go over. And then I'm looking at the paragraph similarly for the suspected child abuse. And part of this is also saying like trauma centers are required to have protocols to do a comprehensive evaluation. So kind of looking for this SNAT, suspected non-abuse, non-accidental trauma. So it probably would be useful to include both of those as like other descriptors here too.
And then you said the other one was the PEDS one?
Yes, for the abuse. I think that one is starts on the page before and kind of overlaps onto that page.
Yeah. This one seems longer than the other ones. Okay, does all of this need to be in here? That's the question. Is this supposed to be ED like this? Yeah.
And then it just needs the title part. And I think this is an added criteria, right?
Mm-hmm. It's new.
So yeah, so new criteria. Okay. New and modified. And then this one is also a new criteria too.
Okay.
So what do you guys think of the examples? Do you think that we need to add more? Does this help for kind of some of these more nuanced scenarios?
This is Heather Gale. I think it works because you put that criteria that you're putting in with the actual rationales, I think will make the examples that much more understanding, you know, what you're trying to do. Because the falls has been a conflict forever. You know, everybody uses different ages. Some people use different criteria, and it's based on what their population is. Like I can tell you our falls, if they're 70 and older and they have a head injury and are on anticoagulation, or even if they're not on anticoagulation, but they have long bone fractures, we still activate. But everybody does things a little different. And we use 70 because when we did our research, that's where we've seen the most injuries with 70 and older. But so I think it helps because I'm with Gail. I didn't know when you were talking about the high profile, the high resource healthcare needs, I was not thinking that it was comorbidities. Yeah. No, I think it looks good. It's simple and to the point, but gives you what the information you need.
Trying to add clarification for Brian.
Yeah, I like that. So I think, you know, throughout the state, and, you know, this really gets into, we don't want scenarios where people think, okay, it's a ground level fall on Coumadin now because our closest level one is, you know, 2-hour drive or hour drive, that we need to fly this person. So we need to just make sure we are clarifying to a trauma center or nearest ED. And I think that captures it. I'm wondering up above where we talked about the red, is it clear, are we clear enough that the red boxes need to go to the highest level trauma center?
So I don't think we have a lot in there for that, other than where it says here, first tier, highest level trauma center available. So we
And it
first
says within,
mentioned it. Yeah, go ahead, sorry.
and that because it goes within the geographic constraints of the regional trauma system. I think that's where each, you know, entity will have to kind of talk about where what that means to them, right? So
Mhm.
Western region, without having a quote unquote level 1 trauma center, that's going to mean something different from Maricopa County, Pima County, or Flagstaff metro area.
Right. I can tell you out here in the Western region, most of our patients go to Vegas because it's the closest highest level trauma center. Sunrise, with Sunrise being a level 2 and UMC being the level 1.
So I just want to make sure we kind of call that out, at least for the red box.
Mhm. Because we do it for here.
Yeah.
Yeah.
All right. Sorry, I didn't start to take us backwards. I just wanted to make sure we hit
No.
that as well.
And then can we go to that pre-verbal slide again? I just want to
Yeah.
make sure. I think I may have kind of misspoken on what I was talking about.
Okay.
I think the first three are perfectly appropriate to be looking at to assist you with determining that they have a motor score of 6. So my only line was, when in doubt, since this is in the red section with a motor score less, that should go to the highest level.
Yeah.
The way we have it in other areas, the highest level.
Yeah. I see what you're saying.
Yeah.
I see what you're saying. Yeah. That makes sense.
If we knock this out in one meeting, I'm going to be really impressed with all of us. No pressure, Amber.
I think we
But-
did pretty good.
I think we are. We're just going to
I
look
have a
at the
couple
other
slides
stuff.
with it.
Mhm.
Just have to add those other slides in.
Yes, and I did share those with Shelley and you as well.
Oh, perfect.
I think it's additional, go a little further down, additional slides to consider. So down in your email, a couple
Oh, this
more.
one. There we go.
Yep.
Perfect.
And then, so these were the first two, kind of the article.
Mm-hmm.
It's like the screenshot of the actual article.
Mm-hmm.
I just think it's nice for EMS to know, like, hey, they actually did take your feedback. And then this is where that was that accepted terminology. So we've already added those in. But for the top two were the systematic review slide.
What about this one?
Yeah, I mean, the question is, do we want to include that? I think that we've included the rationale. We don't need to include those now since we've included the rationale, but those two we can add in.
These two slides. Okay. Okay.
And then do you want to go back to,
Can't find it. I have too many things open on my desktop.
your PowerPoint skills are impressive. I think we've covered those. We included the anticoagulation use stuff. And then we include low-level falls. And that was just the
How about
transport
this one?
decision. Yeah, that was just kind of one of the things that I had put kind of like my summary. And I think it may be useful to include this. Like, we're not telling a trauma center how to activate. This is to really help EMS to identify where to triage a patient to.
Where do you want that one to go? At the review at the bottom?
I think near the end. That's where I put it. It was kind of at
Yeah.
the end of the stab presentation. Kind of before the summary or yeah.
Okay. And then
I think we covered the rest of the stuff
yeah.
because we added that part and that was just the article, but I think we put in these specific rationales. So I think we've got that covered now.
Okay. I can get rid of this one, right?
Yes.
Okay. Guideline update process. Okay. All right. Anything else we want to revisit?
Do you want to look at your Epic stuff that you added near the bottom, the Epic? and
Oh, I
SM?
forgot. I just like forgot all about that. So in here, they had, so after our examples, they have this thing about applying the guidelines. I don't know if we need this necessarily, but I left it in. I just put in a map for pictures. This, I don't know about this one. We don't really have it, anything sort of regionally specific in here. So my thought was to delete this, but I wanted to see what you guys thought. I don't think it really changes this concept for us.
Mm-mm.
I think we shouldn't
So-
go there.
Yeah, I agree.
Well stated, Brian. And
we
actually,
can't re-
right
we can't
above
really-
the map, the one right
Uh-huh.
above.
Uh-huh. You want to delete that one?
Let's just look and see if there's anything not for mass casualties.
That was the only part in here that I thought was like a valid kind of point. But I think people maybe know that already.
Yeah, I think it's probably reasonable to keep, just remind people, know what your local resources are. I don't know, we need sustained education and training. I think we could take the last two bullets off, but
Mhm. Okay. These are the only ones I thought had
yeah.
any information. And then at the end, I put a few slides in about continuation of general trauma care, just per guidelines. I don't know what else to put here. I don't know if we wanted to list this TXA thing, because it will be new, right?
Mm, I would probably err on not including that, only
Okay.
because it's not being like, depending on the geographic area, it's not being universally adopted. So I hate to I don't want to get the training sidelined from the main focus.
Yeah, I agree. Should take away pain management then as well, since it's not really, these are sort of the big things, I guess.
Should we say hemorrhage control?
Say whatever you want, Gail. Hemorrhage control. So I just have a few slides in here that I pulled from the Epic website. I don't know how deep we want to get into this. Just defining primary versus secondary brain injury. What is a potential traumatic brain injury patient? So obviously, I think really the distinction here is just because you're not taking them to a trauma center, that they don't meet the criteria necessarily to go to a level 1 trauma center, doesn't mean that they can't potentially have a traumatic brain injury. So I think here that would be outlined that anything less than a GCS of 14 would be a reason to consider them as a potential TBI. This one I just sort of summarized the H-bombs, so preventing the H-bombs. I don't know if I need like an intro slide to this, but this just comes from our protocol. I don't know if we want to shorten this in any way.
Sorry, to go back to the Epic stuff.
Yeah, yeah.
I'm just wondering if the GCS is going to confuse people, because
Mhm. We could say something like, despite motor score evaluation for trauma triage criteria. I don't know.
yeah, I'm just kind of throwing that out there as a question. I don't know that we need to adjust it, but just want to see what others think about that. Do you think this will confuse people, or not really, because people are pretty in tune with Epic?
I see what you're trying to say with that slide. Any
Mhm.
GCS of 14 or less is you're trying to illustrate, create the potential, your suspicion of index of suspicion high for TBI. So I see what that's trying to accomplish.
Yeah, but we don't want to necessarily confuse people with the whole previous discussion we had about now only using a motor score.
Okay.
I think is the issue, is that we've kind of gone through this whole thing, like, don't calculate a GCS, but now we're saying use a GCS to decide if you have a TBI patient or not.
Let's see.
I tend to think that that could, sorry, it's Marissa, that could confuse people. I think you're thinking in the right way. Is there something else that could indicate a lower GCS without putting that number out there?
I mean, it's really
something simple. I don't know.
Like, yeah, more general, like any change in previous presentation, mental status, something like that, kind of back out a little more generally.
I don't know. I think Dan would have a problem with changing the definition.
Oh dear.
Hi, it's Brian.
Uh-huh.
I think maybe we should just keep the topic to what the topic is. Maybe that would just be better, and not have this be a part of the triage guidelines, because it's going to be hard. It's going to be hard to put this into a matter that reflects the triage guidelines versus keeping it to TBI.
Mm-hmm. Yeah, I mean, I think I don't know. I think what we're trying to avoid is forgetting about all the other trauma care.
So maybe instead of the defining a TBI patient, we focus
get
more
rid
on
of
the,
this?
yeah, maybe we just focus more on the interventions, just a reminder about, as opposed to the definition. So, EPIC TBI care.
So maybe get rid of these two, the primary versus secondary brain injury.
I think that's okay. It's just a reminder, but I think
This one though, just get rid
yes,
of who
I
is a
would get rid
TBI
of that
patient.
one, and
Okay.
then maybe focus more on the care of the patient. So it's kind of saying, okay, these are the things, like you've got your primary brain injury, secondary brain injury. If we were to include that, then at least we're not getting into kind of defining it. It's more just saying, remember to don't include these things.
So then maybe we do the same thing with SMR, right?
Mm-hmm.
So do we want to get rid of this slide?
And maybe we just say, remember your SMR evaluation and training, right? As opposed to all the details.
Mm-hmm. Yeah, because this gets into like low risk, and so I can get rid of those. So say something more like, what was the terminology we used for that? With meeting high risk criteria?
I think you need to evaluate it on all patients who've sustained even a minor injury, right? So like elderly patients can have a ground level fall and a C-spine fracture. So I don't know. I would just say perform spinal evaluation on all patients with suspected injury.
What else? When indicated? I don't understand why these bullets are so weird. Can't make them normal again.
Maybe just perform spinal evaluation on all patients with suspected injury, and then take that one off. And then kind of the next slide, I think there's some key pieces that were, put forward by NAMSP ACS, just about these pieces, which is, SMR cannot be safely performed in patients. So I think maybe just cut these and put that on the other slide.
I agree. Okay. I like that better. And then this is your other slide.
Amber, when you updated that, you accidentally took off injury on your first sentence on that other slide, so you suspected.
Thank you.
You're welcome.
Good catch.
What do you think about that? So we're just at least kind of making, like, hopefully reminding people without getting into too much that
Yeah.
might contradict what's in the actual algorithm.
Mm-hmm. Mm-hmm. Okay. Just have to. It doesn't let me change this back to. I want it to look the same. Why? It won't let me have it. Libri 28. Okay. Okay, that's better. All right, anything we're missing? Anything anyone wants to add, change? Obviously, we'll review this in several other committees before it's finalized, or at least one more committee meeting before it's finalized, so you guys have some opportunities if we need to add something, but thank you all for your input.
Thank you for the time to put it all together so we had something to look at before we just met.
Yeah, sorry, I should have sent it out last night to everybody, but I did not, so
No,
I
it's
was
good.
more behind than I
Hi,
planned to be, but
Hi, it's Brian.
yeah, Brian.
I have one more thing. I've been scrolling
Sure.
through a little bit of this ACS PowerPoint that Shelley sent me a little bit ago, and in order to just make sure we're not about to get lawyers involved in business, all those slides are copyrighted, and I know we've dropped a lot of material. Are we okay, or did they give a general discourse to use it?
General discourse to use.
Okay.
Yep.
Wanted to make sure.
Yep. No, thank you for bringing that up. Yes, they have said that these are out there, or they've made it widely available. You can download from their website to use.
Okay.
Yeah, they don't want you changing their logo or altering the logo in any way.
Yeah. I think they are hoping that people will take and use these for training.
Yeah, I could put on this slide adapted from, and put the citation. And the link. Do we want to link to any of the trauma stuff? I imagine people can find it by Googling.
Yeah, and I've been using, for some reason, I've been using their link on like agendas and to send out, and people will sometimes say that link's not working, and I'll click on the link from where I've copied it and it's not, but then when I just cold type it into like a browser, it works. So I would say, yeah, it is kind of odd. I don't know why. It's happened enough times with enough different browsers and computers that I think they're updating stuff decently.
Okay. All right. Anything else, Gail, you can think of?
I don't think so.
Okay. Go us.
Yeah, this is yeah, I think will be really a huge helpful change. So thank you for everyone for participating today.
Trying to figure out how to get my computer back.
If you stop sharing, there's should be a little X at the bottom bar. You can stop presenting there.
Where?
Kind of look where the red hang up like phone symbol is, and it should be 2 over from that to stop sharing.
Oh, I don't even have that.
Or
You
we
gotta
can
close.
we can just hang up on you too.
Yeah, I was gonna say I definitely. Oh, here you are. I found you. Stop sharing. I just
There we
couldn't get
go.
back to I have 17 different browser windows open, so I can't find the right browser window. Okay,
Perfect.
I'm back now. It's fine. I'm frozen, but
Nope, you're not frozen. You're moving on our
Oh.
screen.
oh, I'm frozen on mine. So if you non-attractive face, it's fine.
Oh.
It's just recorded for the world to see. Thanks, Shelley.
Oh, I'll hit stop.